Hey everyone, welcome to the Choose Health Studio. My name is Sienna, welcome back. I am the community representative at Rancho Family Medical, and today we are joined with Dr. Susan Behnawa. And today we're just going to chat a little bit about specifically Alzheimer's and dementia and kind of talk about that. I don't know a lot about it, and I know a lot of people it can be kind of confusing. You can look at all of this information online, but I think the best thing to do is to get the information straight from our primary care provider. So first off, can you tell us about Alzheimer's, what it is? Start with that.
Yeah, absolutely. And so I think that one of the biggest concerns when you're talking about healthy aging and what that looks like is I don't want to lose who I am, and who you are is housed in your cognitive abilities. So your memory, your ability to interact with other people on a day-to-day basis.
Right.
So when we're talking about dementia, dementia is an overall category of mental condition, medical condition. So basically, when we're looking at dementia, so just like you have flowers as a category, and within that category you have different types of flowers. You have roses, you have daisies, you have peonies. Similarly to that, dementia is a category of illness. All a dementia is a demonstrable cognitive impairment, whatever that looks like, that affects an individual's ability to function and live independently.
Okay.
So when we're talking about dementia, we're trying to move away from the word dementia itself because there's a lot of stigma associated with it. So
what kind of stigma?
So, there's a concern that you become completely dependent, you lose your sense of self, and while we definitely see that in some dementias, I think the word itself is very loaded, and so we're trying as a field to move towards what we call major neurocognitive disorder. And so these are the classifications of what we formerly would refer to as the dementias. So when you're looking at dementias, you're looking at different types. And so within that umbrella, so to speak, you have the main subcategories. And so one of the biggest ones is Alzheimer's type dementia, and we'll get into what that means. You also have a vascular dementia, which basically means any insult or injury to the brain, including a stroke or a bleed, that affects functioning in a cognitive area intimately linked to memory. And so there's vascular dementias, which look very different from Alzheimer's dementia. Then you also have different types of neurodegenerative disorders, like prion disease, that basically causes physical changes in the brain that affect the memory. Then you also have different types of dementia, like, for example, Lewy body dementia or frontotemporal dementia, that are basically different patterns of memory loss. And so if you're looking at, and that's by no means an inclusive list, and so when you're looking at different types of dementia, there are several different types of the disease within the overall category of dementia.
Got it.
If you're looking at overall prevalence, far and away, Alzheimer's type dementia and vascular dementia, which is related to stroke or bleed or insults to the brain, those two are far and away the most common.
Okay, and how do they differ? So when you talk about Alzheimer's versus the vascular dementia, what would be the symptoms in each category then?
So the biggest difference is that when you have an Alzheimer's dementia, it's very gradual memory change. So usually what we would call, the textbook Alzheimer's patient, for lack of a better way to put it, is somebody who is later in life, so usually around their 70s or 80s. They are starting to experience gradual short-term memory loss. So usually when the disease first presents, it's very gradual and very subtle in its presentation, and sometimes it's not noticed until it tends to progress.
So short-term memory loss, is that like not remembering what you ate for breakfast? Is that not remembering what you did last night? Is that what that would look like?
So when you're talking about the short-term memory, we're talking about memory that's created minutes, hours, days. And so these are things like, forgetting conversations that you may have had with a loved one, forgetting appointments that you made, maybe misplacing items, forgetting to do a task that was previously natural to you, like operating the remote or operating the microwave. These are kind of the early subtle changes that we see in Alzheimer's disease. So that's kind of the initial presentation. I think the key distinguishing factor with Alzheimer's disease, distinct from other types of memory loss, is a lot of the times the individual themselves isn't aware of the memory loss. It's usually a friend, a family member, or a loved one who notices it and brings it to the attention of the physician. So when I have our patients come in and they say, I'm really worried that I've been forgetting X, Y, and Z, and I'm concerned that I may be developing a dementia, It's actually quite reassuring to me as a physician
Wow.
because the fact that they have the insight into the memory loss, they're able to give me a detailed recollection of what they forgot and how they were able to recover the memory in the event and compensate for it. That does not equal a clinical dementia. A dementia is usually when you have these gradual changes over time. Maybe someone is getting lost while they're driving a familiar route going to the grocery store, or they forget how to handle a vehicle, so they end up, getting into accidents or getting tickets for going too slow or too fast, or, they're forgetting to do laundry or change their clothes appropriately. So a lot of the times what will happen is, let's say you have a parent and the child lives out of state and will come to visit, and the house is unkempt or the patient's hygiene is suboptimal, and then they'll bring the patient to me, and that's more concerning for me because the patient's not aware of the changes that's happening. And so when the patient is aware of the changes, it's much less likely Alzheimer's versus normal age-related change, or kind of a middle area of the spectrum that we refer to as mild cognitive impairment, or MCI. So there's a lot of grades and subtleties to memory loss, and there's a lot to tease out as a clinician when your patient comes to you.
Okay, wow, that is so interesting. Now, you talked a little bit more about a vascular memory loss.
Right, so when you're talking about Alzheimer's dementia, it's slow, it's subtle, it's progressive. It starts with short-term memory, and then it starts affecting functional ability and independence. When you're talking about a vascular dementia, usually there's a very clear hit that happens at once. A patient falls and has a brain bleed, or they have a stroke that affects their memory. And so the cognitive deficit is immediate, and it may or may not be recoverable. So when we talk about an Alzheimer's dementia, the progression is typically gradual but irreversible. When we talk about a vascular dementia, the progression is usually stepwise because you have something that happens and it levels the ability of the functioning to come down to a certain degree. Depending on the type, for example, a stroke, the hope and the goal is that with aggressive rehabilitation, we recover some of that. Whether it's the physical manifestations of a stroke, weakness, balance problems, gait instability, or the cognitive, forgetting. It could be a very specific area that takes a hit, like language or perception of language or expression of language. But we hope that that's recoverable. Not always, but sometimes it can be.
It can be. Well, okay, so then back to dementia and Alzheimer's. What would the timeline be when you say that it's a gradual progression? Are we looking at a few months, a few years? Does it differ?
So that's a great question. I think overall, the biggest player in looking at what the timeline is for progression of Alzheimer's disease or Alzheimer's dementia is what you're starting with as the patient. And so, for example, if you come to me and we're doing a memory test, if you have a significantly high level of education, you have a graduate degree, you've been practicing at a very high level, there's a lot less room for you to do poorly for me on a memory test. So what I'm expecting is, if your cognitive baseline is high, you have to do well on this test. If you're not literate, or English isn't your first language, or your visuospatial functioning, you didn't go past grade 12, you get a lot more leniency on the cognitive testing because we don't expect you to be able to recover the deficit. So what do I mean by that? People who have higher level of education tend to be able to compensate for the memory loss and actually hide it. And it becomes very interesting because you have people who, let's say they've been very high functioning throughout their life. They've been an attorney, they've been a physician, they've been a scientist, or however, and a lot of what they're doing throughout their day-to-day, because they do it in a habitual and structured way, they end up going on autopilot for it from a memory standpoint. And so, they get up the same way, they get dressed the same way, they go to the same place for their morning coffee, they drive the same routes, so you never really notice a deficit. But you put them in a different city and you give them a different schedule, and then everything kind of falls apart because that procedural memory aspect of it is taken away. And so a lot of our patients, what can happen is there'll be an event that leads to a hospitalization, a heart attack, a pneumonia, a stroke, and they go to the hospital, and then they're do fine in the hospital, but they get discharged to a rehab, for instance, because they don't have that support at home. and it's really hard for them to figure out, where do I go for breakfast?
Knocked out
Who
of their
do I
comfort
ask for help?
zone.
Exactly.
Yeah, wow.
So you lose that procedural memory aspect of it, and it can be really revealing for individuals who are involved in the care, because a lot of the time, dad's at home, he's doing great, but then dad in this new situation is really having a hard time. Or even if they go, to a relative's home and they don't know where anything is, they don't know any of the patterns, so then you notice it more. And so ultimately, to look at an average timeline of progression really depends on the individual themselves and how healthy they are. Generally, we see an average from the time of diagnosis to the time of what we would stage as a moderate to severe dementia at an average of about 5 to 6 years, but that's plus or minus 4 to 5. So it's a very, very wide range. And so a lot of the time, if someone is very, very healthy, otherwise they've been active their whole lives, they've been, eating well, exercising, doing all the things that we kind of know that we're supposed to do, they typically tend to do better. The other thing that plays into, timeline of progression is whether there's a family history or a genetic component at play.
Is Alzheimer's or dementia in general a genetic condition? Are there different risk factors that we can look at to see, yes, you are more likely to get Alzheimer's in the future? Is that something we can mark?
So that's a very tricky question because it actually gets into a lot of the ethics of genetic testing. So if the question is, are there genetic alleles or DNA that has a higher association with Alzheimer's disease or dementia? Absolutely. For example, we know that with Down syndrome, patients with Down syndrome, if they're lucky to live long enough, they will develop Alzheimer's dementia just because of the chromosomal relationship to certain types of genes. There are Alzheimer's genes, though, that there's a very strong association. However, it's not a guarantee that you will develop Alzheimer's disease. And so when you're doing genetic testing, yes, you can have the gene, but you may never develop clinical illness. And what a sword hanging over your head to live your life with. And so I think a lot of us typically discourage genetic testing for Alzheimer's dementia or disease, mainly because we don't really have a treatment or a cure that's reversible for it. And there's no guarantee that even if you have the genes that you will develop Alzheimer's disease. So we do see familial predispositions, especially with stronger genetic variants, but that's not equatable to, yes, you have the gene, you will have the illness. The other thing that's really important to keep in mind when you're doing genetic testing of any sort is, what are you going to do with the information? And so it's almost like being aware that, yes, knowledge is power, but it can be incredibly harmful as well. Absolutely. So I always joke with, when we train medical students and residents, when you're ordering a test, you have to think of it like you're picking your nose in your car. You have to know what you're going to do with what you get. You have to know where you're going to put it and what it means. And so I think a lot of us, especially now the way medicine is practiced, we have access to a lot of tests. But you have to stop and think, will this change my management? And so while, yes, there are genetic predispositions to potentially develop Alzheimer's disease, they're not necessarily complete penetrance, where if you have the gene, you will have the disease. And so we don't routinely test for Alzheimer's disease unless the patient fully understands the implications of the testing and they understand the limitations of treatment that we have.
Wow, that's so fascinating. I know I had taken a 23andMe test, and it showed if I had the genes or didn't have the genes, and it really didn't affect me because I ended up not having any of them. But I can imagine if I did have those markers.
What does that mean for you?
What does that mean as I go about the rest of my life? Do I live in fear? So I understand that. Now, are there any preventative measures for Alzheimer's? Is there anything like superfoods or exercise? Or I know that.
So we get that question a lot, and I think part of it is because it's so intimidating to be faced with something that the biggest problem with Alzheimer's disease is the loss of control, loss of control over who you are, what you do, how you do things. And so there's a lot of research that's actively being done, and well, what can we do, and how do we, if we can't prevent it, how do we at least slow the progression of it? And so I think the best evidence is really for, and I think this is going to surprise no one, exercise. Regular exercise, which we all kind of know we're supposed to be doing. So, we have had studies done where the researchers took a group of individuals and they divided them up into the exercisers and the non-exercisers.
Wow, okay.
And they did baseline MRIs of the brain. And so there are certain areas of the brain that we know are affected in Alzheimer's disease, certain areas that regulate memory. And so the biggest ones are the temporal lobes and the hippocampus. These are just two specific areas of the brain. So all of the research participants got a baseline MRI of the brain, and then 5 years later they went back and they redid the MRIs just to kind of see. And basically everybody had expected age-related atrophy.
Sure.
Obviously there were some big things, but for the most part the exercising group had preservation of their brain volume and mass in these memory areas, you know, the temporal lobes and the hippocampus, compared to the non-exercising groups.
So, and then when we say exercise, is that walking? Is it just staying active?
And so for the participants in this study, it was aerobic exercise, at least 30 minutes a day for at least 5 days per week. And so while we definitely know that there are health benefits to any sort of exercise, they were really looking at the people who were doing consistent heart rate elevating exercise on a regular basis. And these are people who, you know, it's hard to say because even before the study, they have been exercising for, you know, lots of time. But overall, we do see and there's a lot of, so UC Irvine has a memory center, there's a lot of trials that are ongoing looking at exercise and the role in Alzheimer's disease. And I think that for us as clinicians, when we're seeing our patients, we definitely say the key to slowing progression is engaging the mind, whether that's, you know, exercise, being social, which is very, very difficult nowadays, but also challenging the brain. And so when you look at people who are doing, you know, Sudoku and word puzzles and crosswords, that's good, but if you actually study it, all that you do is you become very good at Sudoku. And so when you're talking about engaging the brain, we're really talking about learning a new hobby or learning a new language or challenging yourself on a level that isn't routine. Because even when you're doing these brain tasks, a Rubik's Cube, for instance, you get very good at a Rubik's Cube, but then it falls into pattern recognition.
It's not challenging anymore.
And you're not really challenging yourself. And so exercise, mental stimulation, social and emotional engagement, television and reading are both very passive things. So limiting those in favor of interaction with one another is also a really big deal. Circling back, people are always asking about supplements. So things like, you know, vitamin shots, infusion therapies, Prevagen supplements, all of these things. And I think that it's really nice to be able to think, if I can just take this pill, it'll keep this horrible disease away. But when you look at the evidence, it's just not there. So especially for a lot of vitamin therapies, we have good evidence for vitamin D supplementation. It's great for the immune system, it's great for bone health, it's great for, you know, overall balance, and there's evidence that it decreases risk of falls in community-dwelling older adults. Vitamin B12, if you're deficient, definitely something that needs to be corrected. And then really just getting your nutrition from real food. Plants, you know, savory produce over sweet produce. I think really focusing on that is really the most important thing from a health standpoint.
It always comes back to diet and exercise, doesn't
it? It really does. It's those that kind of foundation of, you know, a healthy lifestyle. The problem is that, you know, vitamins and supplements don't really grow on trees. Our body doesn't really know what to do with them. A lot of the time you're just purchasing expensive urine because a lot of these vitamins are water soluble and you don't have a deficiency. So your body is really good at picking out what it needs and letting go of what it doesn't need. So I think ultimately at the end of the day, good clean food and regular activity, you're never going to go wrong with those two.
Oh my gosh. Well, you have given us so much to think about today, such good advice and information. We so appreciate you being with us, talking about dementia. If you guys have any questions, you're always welcome to reach out to us to ask any other questions, or if you are looking for another primary doctor, Dr. Behnawa is accepting patients at Sun City. So thank you so much for being with us.
Absolutely. And I think ultimately, if there is a memory concern, see your physician, because there's so many nuances that go into diagnosis, and a lot of things from untreated depression, untreated anxiety, suboptimally managed thyroid disease, anemia, all of these things can masquerade as dementia. And so it's really important to have a thorough medical workup and then let your physician take it, you know, from there.
Thank you. That's awesome. Thanks so much.
Of course. My pleasure. I'm always happy to be here in the Rancho studio.
Yes.